Hello, everyone, and welcome to the National Council Center of Excellence Office Hour. Today, we will be discussing integrated care partnerships in school settings. I'm going to give it just a couple of more seconds to allow everyone to enter the space and get settled in, and we are going to kick off today's session.
Thank you so much, Whitney.
Thank you.
Do you mind going to the next slide? Welcome everybody to the follow-up from our webinar on Tuesday, Integrated Care Partnerships in School Settings. We're so excited to have those of you back that were here on Tuesday. Anyone new that wasn't able to join us, the recording is available through the National Council, and you should get an email about that if you registered, or be able to find it on the website. So, so excited to have you here. We are very fortunate that two of our panelists from the webinar on Tuesday were able to join us today, Michelle Thiesfeld and Jamie Martins-Perry. Amy Hill was not available today, sadly, but these two will certainly be able to help with all of your questions. So on Tuesday, we covered, again, integrated care partnerships with schools and school-based health centers. You know, that could be comprehensive school mental health programs, all the way up to a fully fledged integrated primary care, mental health, et cetera, services, school-based health center. We really value this work because so many students report poor mental health, and many have reported increases in poor mental health since the COVID-19 pandemic. And we really believe that school-based healthcare is the solution to that, whether that's mental health services, substance use treatment services, primary care medical services, oral health, vision, all the different things that we can provide in schools where students are to get them the services they need to be well and healthy and successful in school. We will dive into questions first that were shared on the webinar on on Tuesday, sorry, and then we will follow up with any questions that are asked during this session. So without further ado, I am going to ask some questions of Jamie and Michelle. First off, ladies, one question was kind of project focused. People were asking for actual surveys and details regarding who completed surveys, who conducted them. I believe that this was regarding like student data for services in the schools. So do either one of you guys want to take that one?
Yeah, we send out various surveys initially when we go into a school and we're starting services and starting that partnership with the school. We send out a survey that goes to parents, and then we have a child version as well that kids, you know, middle school and up can answer usually. Sometimes we'll have some elementary kiddos answer those as well, and then teachers. And so we like to know what demographic they're coming from and who's answering those, but they answer kind of the same questions, really their acceptability of mental health services, as well as what their knowledge base is and what they want to expand their knowledge on and what they feel like are needs in the school district, that kind of thing. And then we do that again at the end of the year to see, you know, did we miss anything? And are there gaps? And do we need to improve in certain areas? And what areas do we need to change that in so that we can continue to build on those programs? And so we try to send those out at the beginning and then at the end of each year.
Awesome, thanks, Michelle. Jamie, does your organization do surveys?
Yeah, so we do surveys for youth and parents twice a year. And so ours falls in February and October. We just ask how our service is going, what can we do better, provide us with some ideas if, you know, there's anything we could be doing better or differently. And then we send our districts a survey at the end of every year around April. And it's just, you know, how are we doing in your district? What positive improvements are you seeing in your youth? And overall, it's usually like better classroom management, able to recognize their emotions and start to self-regulate, less out of school suspensions, better attendance, better grades. So we get really good results from administration as well as parents and kids. Typically we get about a little over 500 responses from parents and kids.
That's awesome.
Mhm.
Thank you, ladies. So another question regarding starting up partnerships. So this one is asking about metrics of qualification for a school-based health center program to begin to be implemented in an academic setting. So I know that neither of your programs are technically school-based health centers. Maybe you could speak to that from a school-based mental health program perspective, like sort of what you look at for a program to be needed and a fit for a school.
I can go first this time, Michelle. So we started ours in Illinois based on the free and reduced lunch population, knowing that we're a community mental health organization. We wanted to, expand our services to kids who we knew would have barriers getting to treatment anyways. And so we started by offering school-based services to one, a large population of where we had students coming from, and two, a large population of our medical card holders or Medicaid population. And so our first 10 or so schools were youth or schools who had district averages of free and reduced lunch of about 90% or up. And so we knew the majority of the referrals we would be getting would be kids who would have barriers typically to regular treatment or office-based treatment. But then honestly, once we did that, it just sort of, I've said this before, it just sort of spread like wildfire. So the school districts told other school districts, and then that's just how it just kept growing that way. So based on the population of students is how you staff it, by need of school, and then also by need of the population, depending on private insurance or Medicaid.
And I don't know the demographics or how that works in other states, but we live in a very very rural area, and so access to services for some are an hour and a half one way before they can find a therapist, and then even then there might only be one therapist in that area, and so they can't cover that large of a radius. And so a lot of our schools and for some of our school districts, people are traveling 45 minutes just to get to school because all the schools have combined in all of these little areas. And so their districts are very, very large as far as distance from their home to the school. So we've looked at a lot of those pieces, like where is the need, because they're not getting services. And then in talking with schools, like what can we do to support you? And some schools have said, hey, you know what, we have resources that we don't need that bachelor's level skill-based person in the building, but we really need a mental health therapist. And others have said, the mental health therapist will be really beneficial, but we really need to get that skill one in right away. And so we try to balance what the school is needing, but the communication, honestly, I could throw a dart and go anywhere in our area, and there's a lack of access to services, and because we just don't have it. And even in our bigger towns, we only have 2, maybe 3 therapists total, and that's covering adults and children. So it's really been based on what we can provide, because we also have to have therapist availability, and we don't have a lot of that either right now. Applications are slim just because we don't have them.
Thank you so much. And I'll chime in from the school-based health center perspective as well. At the National School-Based Health Alliance, we have a really cool tool called the Children's Health and Education Mapping Tool. I just put an announcement from December. We added some new capabilities in the chat, but if you want to look sort of across the country and then hone in on your local area regarding disparities in health, education, socioeconomic status, health delivery systems, other key indicators, you can really like sift through data. If you're a mapping nerd, it's pretty fun. My husband loves it. So you can really look at where those kind of intersections of need are, where there's a whole bunch of needs in one area, and target an SPHC there. And then, as Jamie and Michelle were saying, same for school-based health centers. You've really got to look at your local state down to local situations, needs, what you hear from your community. There are a lot of different ways to assess this. So couple tools that you can look at. Regarding sustainability, great question. So they would love to hear about the value-based care and potential savings related to investing in this type of work. Like what kind of savings arguments can you guys make?
I'm probably, and I don't know, again, how other programs are ran, but with our partnership, the school does have some investment in it, and they do put some funds into it to bring us in. And part of that helps with us being able to have that collaborative piece that I think is so important in building those relationships. But it also allows us to have some opportunities for kiddos that maybe don't have insurance, because they still need to be able to be served as well. Sustainability is always the key issue. A lot of times schools start by having a grant, and then they have to figure out how to work that into their budget so that they can maintain and sustain that. But what we have found is that we haven't had a problem doing that, because they're seeing so much need in the district that isn't being served. And then by being able to provide it, either kids are in seats more than what they were, or they're, in addition, they're showing progress and improvement. And so that alone is what gives them that desire for sustainability. Not just a cost difference, but they're saying, hey, we're seeing what is needed for our kids, and their mental health is improving. And so we're going to make this work. In fact, last week I had a conversation with the superintendent that said, if I went to my school board today and said, I can't figure out how to fund this another year, they would say, well, figure it out, because it's not an option. This is a non-negotiable, because there is such a need that I think that you make yourself as valuable as you need to be so that you're not replaceable. If that makes sense.
Yeah, this is Jamie. I think our sustainability concept has always been being able to bill. However, like Michelle, we have started, so for 8 years, we did not ask money from any of our districts. And so this summer, I've been tasked with asking our districts, and I can see the value because I will ask a district, and we base it on, how many staff are in their district, and how many days a week they're in their district. And when I said what I, would like for their contribution to be, they were all like, oh, okay, well, I'll have my board approve that at the next meeting. It was nothing. And it's very, in my opinion, it's small for a district, but I don't know what districts, financial states are. So I've already met of the 27 districts, I've met with 7 of them, all 7, like on the call. The superintendents were like, yes, absolutely. And that's all you want. So now I'm like, well, I should have asked. But I think it's just, and then also in the state of Illinois, our billing rates have increased as of July 1. So I think the sustainability piece will be there. And now that I know the superintendents or the districts are willing to put, budgeted money aside to keep us there, I think the sustainability piece is, it kind of figures itself out. Like Michelle was saying, there's such a need that they just can't imagine life without a mental health professionals embedded.
So once you've gotten in and done a good job, they're ready to keep you forever.
Right.
Yeah.
And you have that productivity number that you need clinicians to meet,
Sure.
whether it be the bachelor's level or the master's level. But if the schools are invested at a certain level, they also feel like they have some ownership of it, versus we're just this implant that's been put in there. That partnership allows everybody to feel more cohesive and for everybody to feel more valued. And like again, that word ownership, but it's their program as well, not just us coming in and giving them something, they're building it with us.
Absolutely. So big picture, I think as with so many programs, it's this patchwork of things that, contracts with schools as well as billing, productivity time. Some people have grants. I know that if you're a certified community behavioral health center, sometimes there is additional funding to kind of fill in those gaps in services, to provide services for people who are uninsured or underinsured. And the other thing that I was thinking about in terms of value, big picture, which is always hard to quantify, but this idea that in your community, if there's heavy use of the emergency room for crisis services, or you're seeing a lot of adolescents and adults who have had these mental health issues untreated for a long, long time, showing up later with more intense needs in the different care settings, that's a strong argument for these school-based health services too, to get in early and provide care before young people really, really need it, that we're meeting them where they're at and getting them care ahead of time before they're just in the ER all the time. Side note on the sustainability question, but I think that it can really impact savings long-term over the whole lifespan. Just to add that in.
I think that in our region, our county mental health region in Iowa, they have funds for what is called mobile crisis. And so in addition to our school-based services, we have a mobile crisis team that can come out, and it's solely put together because they're trying to decrease the number of ER visits. If our therapist and our youth mental health worker isn't available, we have another team that can come in. And so it's available everywhere, but our schools are more likely to access it because we're there as well.
And that's another value add for the school, that they don't provide mental health crisis services, but via the contract and connection with the organizations providing school-based mental health services, they can also access those. Awesome. So let me look at our next question. So kind of a follow-up to that, other logistic and reimbursement ideas to help partnerships be more successful. Do you guys have other ideas, or do you feel like you kind of already covered that one?
I think sustainability through billing, contributions from school, and then our third one is always like random grants. So right now, I think out of 47 staff, I think I probably have between 13 and 15 covered in just random grants.
Which is always hard because there's an ebb and flow there, but there is usually some grant funding that if you can track it down. And sometimes depending on if you can apply in partnership with the school, or depending on what the grant is, those partnerships can be an asset as well. So moving along to rural communities, Michelle, this might be right up your anything that would be helpful to folks trying to work in rural communities, any advice that you would give to getting it started, anything people need to look out for?
I think that in those rural communities, it's the reality that we have limited services. And so we have to pool together what we have. And if we can come together as a team to provide those, that's huge. And so finding what works and knowing and understanding that what works in one district is not going to be what works in another district, because everybody has different types of resources in their area, or they may be closer to something than what you're closer to, and vice versa. And so being aware of what you have available and then trying to pool that, develop a team. I think that that's what's helped us be successful, is being a team with our schools, where my staff are definitely they work through me, under me, whatever, however you want to look at that, but they also are staff at the schools. And so it helps develop that sustainability, and it helps with that level of burnout, and it helps with all of those pieces when you're in these small areas, if you can have that partnership and that team.
Jamie, anything you want to add?
I think, we're not rural, but a little bit of the same. As long as everybody's working together to pool in resources, usually, even if we are asked to more rural communities, we usually will say, well, this is who covers that area, or we don't want to step on their toe, but if they have no resources, and I've already asked that community mental health agency or whatever's closer, for instance, in one of our most rural districts, there are two community mental health agencies. So one takes care of the elementary school and one takes care of the junior high school.
Gotcha. Yeah, I know this is great to think about. I know that things can be different. I was a provider in a rural area. I totally hear you. And I think that teaming isn't always easy. I guess it would be kind of my reflection that everybody doesn't always get along perfectly. Everybody doesn't always want to work together. And so that's something I think about a lot, is like, just don't give up. It's, just like we don't give up on our clients, we don't give up on our partners, and we find ways to make it work. I can see Michelle nodding. So I'm going to do a shift to client-focused questions, clinical-focused questions. How to engage with difficult clients. And I think this was, in the school setting, if you've got kind of folks who need a higher level of care or have some difficult diagnoses.
Just build a relationship. That's really, up to each therapist to be able to build a relationship with each kid, provide, whatever it is, meet the kid where they're at, meet the family where they're at. So if they're not ready for treatment, if they have really specific diagnoses that, make it hard for them to want to engage in school, and then we kind of pivot and shift. And if we need to do at-home services for a while, we do, or if they want to come to the office, whatever makes them most comfortable. And then, of course, we can't help everybody. So if it's a situation where the client doesn't want to engage, or services are not going to be best served in the school, then we link them to the best resource.
All the things that she just said, 85% of your progress is based on your relationship. And so if you can't build a relationship, then you have to look at what are other resources that can. And so knowing that it's okay to say that you can't, or knowing it's okay to advocate for what is needed.
Yeah, thank you guys. And I was sort of thinking about, probably similarly to how you would engage with difficult clients in the community behavioral health setting, in the outpatient clinic. But also an asset in the school is that you do have that team, and you have teachers there and other folks that, are interacting with this client, and you can really, with appropriate releases of information, you can maybe help them better in the school setting, has been my experience.
I think you have some other resources in the school too, and it might be intimidating to come into a therapy office. And so you might be able to do that in a gym. If you know that it can be private, and you know that it can be secure, because maybe everybody's gone for the day or whatever that is. So you have some more opportunities to be able to have some of those interactions that maybe feel safer until you can move into the office.
Awesome. I'm going to jump ahead to some questions about workforce. I know we shared this on the webinar that as diverse as all of the different sites we interviewed for this project are around the country providing school-based mental health services, the very clear common denominator is that everyone is having trouble staying fully staffed, finding enough clinicians and providers. And so we have one question from someone in Georgia that says we have a huge issue with turnover because the workload is really high, compared to the pay that providers receive. Is that an issue where you are, and how do you combat that?
It's definitely an issue where I am. We didn't combat that for years. And I think COVID made our agency see that it wasn't going to get better. And it in fact got way worse. And so some funding from the state, the increased Medicaid reimbursement rates. Thankfully, my company increased all the salary, like the salary ranges. And so we are at $15 an hour for very entry level positions. And so my level 3 clinicians who are master's level, my level 4 clinicians who are masters and licensed, they literally can make a livable salary now. And so that all just started on July 1. And I know that other states may have not gotten, some of the stipends from COVID, or their Medicaid rates have not increased, but just advocate for those, especially for Medicaid rates to increase, because I can't say yet that we're getting like droves of people applying because nobody knows that we've increased. But I will say this, I would just be very open and upfront when people did apply and say, hey, this is what you're going to be at. And I just want you to know that, because let's not waste anybody's time. And 90% of the time they'd be like, oh yeah, I'm not gonna be able to do that. Like, I can work at Starbucks or Target and make the same. And I have a master's degree and I really want to use it, but that's not feasible. But now I feel comfortable saying, this is what our new master's level clinician makes, or this is what a new licensed clinician makes. And it's very livable and doable. And so I'm so thankful. It was years in the works, and it finally happened. So advocating it at the state level for Medicaid increases so that you can pay mental health and substance use staff more, or advocating within your agencies, whatever extra dollars can that be for, staff and retention of staff. We also did add a bonus structure this year. And so I feel like, man, staff that have been here a while are starting to love their life. And because it is a very hard job. There's a lot. If my school-based clinicians are hearing anywhere between 35 and 40 stories a week, which we know 90% of them are trauma-based. And so it's a lot. It's a lot to take on.
Yeah, I'm very excited to hear you guys got an increase. We have not had one through Medicaid in over 10 years. So
we did not for 12. So
yeah. So I'm really hopeful that will come eventually. But, one of the things, because of our partnership with schools and because they have some financial obligation to it, it allows us to lower our productivity rate for our school-based. So if you're in office here at Season Center, your productivity rate is 100 billable hours. So we do 45-minute sessions. And so that's a 0.75. So you have to have 100 of that. So, or of the hours. In the schools, depending on which contract you're at, you're either at 80 billable hours or 90 billable hours. And so that is definitely a draw to know that they're seeing less people. And they're done usually by 3 as far as direct time. So then from 3 to 5, they have paperwork time. So it's not as overwhelming to try and figure out how to balance your paperwork and your clients. I do think that we have a pretty decent salary range. I would like to see some change in different areas, but I think that's anybody. But I think that we're pretty competitive in that, because you have to be. And I think that bonus, like you talked about, we're implementing some productivity bonuses and with our therapist and at the master's level. And now we're working on trying to figure out how to do that with our bachelor's level as well, because they need to have something that makes them feel valued. And we all know that giving a pen isn't going to do that. And so right now in today's society, financial bonuses are the best way to do that.
And I'm seeing signing bonuses now too.
Yes.
In the past, and I don't know if you guys, like in rural areas, we would often see for healthcare, like primary care medical providers, we would see signing bonuses to get them to come to rural areas. And now I'm seeing that a lot for behavioral health as well, just to get them in the door.
Our sign-on bonuses are anywhere from like 5,000 to 10,000 right now.
Oh, not ours.
Yeah.
So if anybody wants to move to Iowa, I'll take
just a little plug.
Ours are like between 1,500 and 2,000 or 3,000.
Gotcha.
But we do have like 1,000 employees. So.
Yeah, we do not.
Yeah. Yeah. Good representation of the different areas of the country, different operations. I'm also going to put in the chat, our fabulous partners at the National Council have a great brief called Behavioral Health Workforce is a National Crisis, Immediate Policy Actions for States. So if you guys are looking to, anyone's looking to work on this issue, definitely read that. Questions about, so how do you cover the cost of students without insurance?
We use the grant dollars and or that dollar amount that we get from the school to help with some of that. We also have a sliding scale that our agency uses to help with that. And we look at EAPs when possible.
Same, all the same.
And are you serving students with private insurance as well?
Yes.
Yes.
Awesome. Yeah. So depending on licensure, depending on the state, you can serve those students. Awesome. Yeah, it's really great in the school setting. Really, you want to be able to serve all students.
Yeah.
It's my not so humble opinion. And I know some programs start out, we can only serve Medicaid, whatever, we need to get this grant funding to serve uninsured students, but really aiming to be able to provide services for everyone, because that's the best way to go. And it also reduces stigma if it's accessible to everyone.
Right. And that's for our bachelor's level, they can only bill Medicaid, but they can still see non-Medicaid. And again, that's from that partnership with the school. Those dollars allow us to see those kiddos on that bachelor's level as well. And so we serve a lot of kids with our bachelor's level provider doing skill work and emotion regulation and that kind of thing, or classroom work based on that from the school.
What does your contract with your clinicians look like? Are they part-time, full-time, 10 months a year benefits? If they're working in the schools, are they off in the summers or not? And what kind of benefits do you provide?
Do you want to go first? Or do you want me to jump in?
Go ahead.
Ours are full-time. And so summer months, we know they're not going to hit productivity because it reduces by about half. The reality is, and because we have camp, I'm able to do camp evals with my school therapist. So they do a lot of our camp evals. It's also their opportunity to do the behavioral health intervention assessments. We try to schedule those so that they're July and December on that 6-month rotation when we can, so that they're busier with that. But it's a great opportunity for them to do different things during that. And then I send some of my bachelor's level staff out to camp, and they provide BHIS services 2 days a week at camp. But yeah, they are full-time, full benefits.
I put the link to Camp Autumn in the chat as well. If you guys weren't on the webinar, be sure to check that out. It's pretty awesome.
It is awesome. We don't have a name for ours, but similar. So we have full-time year-round, full-time benefits. We do call them camps, but not as cool as Camp Autumn. But what ours is, are just like a different topic every week. And then clients know that they can sign up for them based on the sort of the topics that we send out. So 1 week we might, show Encanto and do grief. Or is that the right movie? I can't keep up. We usually do for our younger kids, it's like a Disney movie and whatever that topic is. And then we do groups regarding that, based around that movie. And then for our older kids, it's just sort of random. But we do have them come to our buildings from like 9 to 3. We used to, pre-COVID, have vans and go pick all the kids up and bring them in for breakfast. But since COVID, we have not done that. Actually, this is the first summer back of doing groups since COVID. So lots of kids here and a lot of fun groups.
A lot of our schools have free breakfast and free lunch throughout the summer.
Yeah.
And so that brings kiddos in. And so some of my clinicians and staff are able to grab kiddos during that time too. But I'm liking this idea of this weekly thing that could be implemented in schools. So thank you.
Yeah, we do it Monday through Thursday from like 9 to 3. We have a church that brings lunches every day. And sometimes the groups, if we have like a donor, and we have one this year, somebody just randomly donated $500. So one of the groups is around the youth, like kind of social skills. So they pick out the schedule for Tuesday through Thursday. They then have to go to the grocery store and then they cook it.
That's awesome. And I know across the 12 different organizations we interviewed for this project, not all do this in the summer, not all run these kinds of summer programs, but I am partial to them. I think there's a lot of value in them. One of the organizations we interviewed where I used to work, we did summer programming as well, super rural area, and we tied it in not only with those meal programs that Michelle was referring to, but also got some side funding, a side grant for busing, and we're able to bring in young people who were then able to go attend swim lessons in addition to some of the mental health activities. So just, good summer fun from the kids' perspective, some skill building, but also had the mental health focus and the skills training and kind of treatment focus for them. So there's a lot of really cool creative things you can do in the summer if you have that structure. I know that Amy answered this question yesterday. So it's how are clinicians paid? I cannot imagine at the beginning of a program that there's a constant flow of students for the clinic or mental health clinician to bill. How did you float some of these revenue inconsistencies? And I know that Amy on the webinar on Tuesday said that has not been an issue for them, that when they start services, they are so booked up immediately that, there's not much of a window where they're not kind of billing at full capacity. How about for you, Jamie and Michelle?
So we let schools know when they give us 20, depending on how many days a week they want us. Let's say they say, well, yeah, we see a need, we want you 4 to 5 days. We let them know that we will embed a clinician once they've given us 25 to 30 referrals. Because then a clinician is half, let's say half of those work out, then they have a good start.
We probably eat a lot on it. We start them and they have 6, we hope that within 6 months they're up to productivity. And so we just kind of go with it and work on building that and establishing them and do a lot of outreach during that time to help educate the school. And we use a lot of that time that is more the collaborative piece, because they're not going to have as much collaborative time once they get going. So they spend a lot of time developing the foundation in the school during that time as they're building their caseload.
Really doing outreach to teachers, administrators, building those relationships. So
they go to the hospital and to the clinics and talk to our providers and work on referrals through there as well. Department of Human Services, juvenile court, just really putting the program out there and also just establishing what they need to, working with the SEL team at the school and the MTSS and PBIS programs, and just really working to build that during that time.
Let me throw out, Michelle, tell me if I get these acronyms right. Social emotional learning, multi-tiered system of supports, positive behavior intervention system. Is it system?
Yeah, I'm glad you knew what they were.
Awesome. Yes, very common school language. So if you are not coming from the school, these are acronyms you'll hear a whole bunch. I'm not sure I got the S in PBIS right, but all the teams that are working on positive school environment, positive social emotional stuff for students. So yeah, great call, Michelle. Those are all good acronyms to know. Jamie, did you want to add something? And Jamie, this one was especially for you, and I think you've already answered some of this, but if there's anything you want to add, do the schools pay Chestnut an annual contract fee? And for billing, does Chestnut bill for every child seen within the school setting? Do they bill the state, private insurance, etc.? I think you've covered this, but if you want to add anything.
Sure. So yes, we try to bill every client, depending on what their insurance is. That might not be feasible. So let's say I have a master's level clinician embedded in a school and we have 5 or 6 private insurance kids. So they cannot bill for that youth. So we would just see them, use some grant dollars to cover that, or maybe the school's contribution. So we don't turn anybody away. If possible, sometimes we create what I call an L floater position. And that's a licensed clinician who then would just go sort of like to a couple schools a week to cover the private insured clients. So we've had that for a couple of years, but hiring a licensed clinician in a community mental health center is sort of like finding a unicorn. Or keeping them, I'll say that, because once they can go to private practice, that's typically where they head.
Yeah. Again, back to the workforce challenges.
Yes.
So I have one more question that came up in the webinar on Tuesday, and then I will move to the questions that have popped up in the Q&A and chat in this session. And just so you know, if you asked a question, I will flag it and ask if you want to unmute, turn your video on, and ask directly, verbally. And if not, no worries. I will repeat the question. So last question from Tuesday, Jamie and Michelle: does a parent or guardian have to participate, like via Zoom, telephone, or in person each week during the child's session at the school?
So for us, no, we wish that they would. We hope that they will. They do have to participate in the intake process and the treatment planning. They need to sign consents. And then at a minimum, we have a contact with them once a month. We always invite parents, you know, let's do Zoom, let's do phone. A lot of our districts will let us invite the families in. If that's an option for the parent or guardian to make it there. I'm not going to say that happens a whole heck of a lot, but you know, once a month is minimum. We would love for a lot more. But so at the very minimum though, we have to talk to a parent about progress and what's going on every 3 months.
I would say we're pretty much identical to that. I would say that that's the biggest barrier to school-based services is the lack of parent involvement and the lack of investment that comes from parents. And I think that that's why we see our numbers drop in the summer, because parents haven't had to be invested. And for some, it's simply because they can't, you know, their job doesn't allow it. And I respect and value that completely. But on other sides of that, there's just a lack of investment because it's easier to allow that. But my take on that is then at least the kiddos are getting services and support that they wouldn't be getting otherwise. So my clinicians have to reach out monthly. I would like them to reach out at least monthly, but for sure, like you said, that quarterly contact is huge.
Yeah, it's such a fine line between the, you know, the convenience and access to care in the school setting and young people getting the services they need, but then also really wanting to involve parents, some of whom may be working, like you said, Michelle, and not always totally available. But yeah, definitely a challenge. Much as school-based healthcare makes, you know, those services more accessible, it also does kind of change how they look for some families. Yeah, that was a great question. I knew you guys would love that one. So I'm going to move to the questions in the Q&A first. I know that we had several from Allison Gary. Allison, do you want to unmute and ask your questions live? Actually, I do not know if Allison can do that. Whitney, you know what? Yep, you're right, Allison. I don't know that because it's a webinar format, I don't know that you can do that. I apologize. I just teased you and now I can't follow through on my offer. So Allison, I will read them for you. I apologize. So Allison's first question was, how are referrals made? Can students self-select for services? And if so, how does the privacy piece with parents work? And actually that does remind me, ladies, I know that on Tuesday, people were asking about HIPAA, FERPA, how do you manage privacy in schools? Super common question. So go for it.
So our referrals, they can come from really whoever. So it can be the school can do the referral, the child themselves, the parent. It doesn't matter for us really what door they come through, we will link them to the most accessible service to them. So if it's through just our central access line, we will say we have a school-based clinician. Would you like your child to be seen at school? And then we route them as needed. A child, we do have a ton of kids who self-refer once they know we're embedded in their school, and they'll say, well, my friend sees, you know, so-and-so for therapy. I got some stuff going on. Can I start doing that? So a ton of self-referrals. As far as consent and HIPAA and all those things, we do that pretty much up front. So in Illinois, we are allowed to see a student for 8 sessions for 45 minutes before we have to have parental consent. And then at that time, we would have to stop services if we didn't engage with the family and get consent. But there's a little caveat in Illinois that over 12 and over, the parent has to consent, but then the child does not have to consent for the parent to receive their info. We do always require the family to consent to us, A, providing services in the school, but B, being able to relay information back and forth with the school.
I would just agree with referrals, you know, anybody can make those. One of our districts is very focused on those individuals being very school need, like there's a definite need in the school for why they're getting it. in order to see their therapist, but the rest of mine are very open that anybody can. However, if a child accesses that, we do have to have parental permission, and there's not an age for us. It's everybody has to have that. There is with substance use, that is a little bit different because of some of our policies and licenses, that if there's substance use, then the child has to sign releases of information for that. But one of our releases that are included in our packet is for the school, so that even just for us to say, hey, I'm seeing this kiddo, I need to have a release of information. For them to say, hey, I need to get their schedule, or hey, can you call this kiddo down to the office for me? Whatever that might be. So we do have releases for that, and parents can choose what level of communication is had. But I think that's probably one of the hardest things, is for teachers to understand, they want all the goods sometimes, and we have to say, no, that's not our job. Our job is to help you learn how to manage or help them in the classroom, but we're not going to give you that background information, because that's beyond the necessity of shared communication. So we do a lot of education, not just for our clinicians, but for teachers to understand what truly is necessary information for them to have.
Yeah, that was another piece that was sort of jumping to mind as you were both talking, is sort of that like workflow in the school setting, like where, these referrals might be coming from a lot of different directions, and how are you managing that, and how are you helping your partners learn how to navigate both the referrals and the privacy need versus what's not shareable.
If the referral is coming in from a teacher, we ask that goes to the school counselor or administration first, and then they reach out and make contact with the family before we do. So we're not making cold calls, so that they're not like, oh, why are you calling me? But saying, hey, this teacher has referred this kiddo thinking that this would be helpful. And then we can call after they get the okay and say, okay, this is who I am, and how can we work together to get services set up? So we do, like, if the school is making the referral, we want the school to have a part in establishing that relationship, and then we take over from there.
Awesome. And I saw Angela asked for the season's website, Michelle, so I shared that. And so it turns out, you guys, you can be unmuted. It's just that Paula will have to do it for me. So Allison has another question. Paula, if you don't mind unmuting her, we can let her ask her next question.
I think I'm unmuted. Can you hear me?
Yes.
Okay, so I'm glad you kind of brought up the challenge around minimum necessary with teachers, because I'm sort of thinking around the other types of trainings and support that the teachers might need. What does that look like? And we know that teachers have a huge administrative burden already, and they're not licensed clinicians. And so how do you sort of navigate that with the teachers? What type of trainings do you offer, and what other resources help within the context of your programs?
It's kind of a big question, because there's all kinds of trainings that we do with our teachers. Like right now, we're in the process of getting some of our bachelor's level trained to be trainers for sunshine circles through TheraPlay, and then they will implement that into the classrooms as well. So there's all kinds of trainings like that. And for example, I'm an assist trainer, and so I go in and can provide assist training with the schools and different things like that. So there's always those kinds of trainings, but we also try to do during like their professional development days, going in and providing some quick classroom management training on how to manage anxiety, or how to manage this, or what are some tools and tricks that we can offer you. And so we try to do quick 30-minute presentations during some of their PD days, so that they can just get some added additional help with different mental health needs or behavioral needs. If teachers come and say, hey, I'm really struggling with this, being able to do some classroom observation, and then giving them tools of what they can help with in their classroom, things that we might know, or how to manage that trauma-informed space and how to use it, training on how to use the sensory room and the importance of it, because I think sometimes teachers feel like it's a play zone and not what it needs to be used for. And so trying to educate on that, trying to educate on the idea of confidentiality and why it's important, and why kiddos need to be able to come into sessions. And so I think it's just important to recognize what the needs are in the school and try and adapt trainings to what those needs are. Does that help or answer that?
Yeah, that's awesome. I love the idea of doing the observations in the classrooms. I think that has so much value, because it's just that direct piece that the teachers might just be struggling with that will either help buy-in or, you know, going to create additional barriers if they don't get it. Yep.
So
Allison.
oh, go ahead.
Oh, go ahead, Jamie.
Yeah, so when we get involved with schools, we often let them know that we, at a minimum, we want all of their teachers, lunch men or women, whoever, in the district to be trained minimally in youth mental health first aid, which we provide. Then we also do like a 3-part series of like how to create a trauma-informed classroom. And so a lot of our districts take part in that. And then like Michelle was saying, just random little trainings that pop up that they're interested in. We don't do too many just observations that are, you know, longer than 15 or so minutes. But I think that would be something helpful for the future.
And
I think those are wonderful.
Allison, I'm going to quickly put some links in the chat as these ladies are talking. I just dropped in the Sunshine Circles that Michelle mentioned, as well as the Association for Play Therapy website. I'm a dedicated play therapist. It's just a little bias on my part. And then also Youth Mental Health First Aid, I'll drop in amazing program and assist. I'll stick in there so you guys can see what they're talking about. Allison, you had another question about, is anyone working with a commercially insured population? Do you want to ask that one since you're on?
Sure. Yeah, I was just wondering how that works in terms of, you know, just the billing piece and just what that looks like.
Our office just sends out the bills for the copays. In the schools, I don't expect kids to bring copays.
Mm-hmm. Yeah. I think, you know, sort of like with the self-referred kids, you know, I mean, I don't expect like a 12-year-old to have their insurance card on hand. So, you know, does that ever become a challenge with if parents don't have to consent and then they're getting hit with copays or deductibles or anything like that?
Mine have to consent. So that's a total Jamie question.
Okay.
So they do, if, you know, after the 8 sessions, they would know then, and then we would start billing. Typically it doesn't get that far, right? It's very rare that we do 8 sessions with the kid where we didn't have consent. And I would say it's even rarer to do 8 sessions with a kid with private insurance. I don't know that we've ever done that.
Got it.
Yeah.
Thank you.
My next question is from Jonathan. Thank you for the great questions. That was awesome. Next question is from Jonathan McKay or Mackay. Jonathan, do you want to ask your question live?
Could you read the question? I've been taking so many notes that now I'm thinking about a different topic.
Absolutely, sure. And I think some of this has been answered, but I think there will be some additions. So what if a student needs help that is uninsured? How do you cover those costs? What about students with private insurance? Who checks on covered benefits and does billing?
Our support staff here does all of our checking on benefits and our billing, and a lot of times we'll send out DocuSigns to get all of our paperwork done and to get our copies of insurance and all of those pieces together.
Exactly the same.
It's good we're consistent here. Any
I will
follow-up
say
questions?
though, we have electronic medical records, so you know, when our clinician writes the note, it becomes a bill, and that's
Yes.
makes life a lot easier.
Same.
Awesome. And I have a question from Daria Keys, if you want to unmute and ask. And then the next one will be from Angela Page. So you're on deck, Angela. And if Daria wants to unmute, we can answer your question. Or be unmuted, my apologies. I'm going to read the question so we can be thinking about it. I'm interested to know what evidence-based practices you use. We're trying to decide on CBITS, which is cognitive behavioral. I'm blanking on this. Jamie knows what it is. for trauma in schools. Is that right? Yeah. Okay. Close. Bounce back and trauma focused CBT. Daria, feel free to correct me if I got any of those wrong.
We use all of those. Those are the most used, I would say. Trauma focused CBT, just regular CBT. We do use groups for CBIT. Yeah, I think that you got them. Bounce back is for littler ones, so we use that.
We would add in Theraplay. We have some that are doing some EMDR now. We do a lot of DBT, some DBT groups with our teenagers, especially, yeah, those would be our primary.
And I'm getting flagged for time, so I'm gonna wrap it up. There was a question about any handouts or education for teachers about HIPAA or FERPA information sharing. Real quick, do you guys have any like documents you share or links or anything like that?
I don't.
This is a great question, and we need more of these. Oh, Jamie, do you?
We just give them like a brochure pamphlet that explains to them what HIPAA is, and they sign something saying they received it, and they'll read it, and they'll ask us if they have questions.
Jamie, if you wouldn't mind sharing that with me, that's a great segue to the resource that we are developing with the National Council through all these interviews we've done that resulted in this webinar Tuesday and the office hours today. We're developing a resource for community behavioral health programs, CCBHCs that want to start working in schools, whether via school-based mental health programs, fully fledged school-based health centers, and that will be coming out shortly in the next few weeks. Later this summer. So keep an eye out for that. Be sure to sign up for National School-Based Health Alliance listserv, as well as the National Council for Mental Wellbeing, so that you can be notified when that comes. And then we will share resources like the one that we just talked about with Jamie via that resource. I am going to stop talking now and let Whitney wrap it up. Thank you both so much for your time. This has been amazing. So appreciated.
Thanks, Katie, and thanks to our panelist speakers, Michelle and Jamie, for joining us today. Just to be mindful of time, I'm going to go ahead and begin to close today's office hour session. Let me share some of our resources that we have here. Okay, so we do have some resources. We will be sharing this slide deck so that you can have access to them by tomorrow. But just wanted to highlight some of our upcoming Center of Excellence events that are shown here on the screen. The COE will be hosting part 4 of the perinatal health webinar series on Thursday, July 21st from 2 to 3 p.m. The link to register is on this slide here, but it's also on our webpage. Also, we have the part 4 of the CHI, the Comprehensive Health Integration Framework, and it's going to be focusing on payment models for comprehensive health integration, and that's also happening on July 27th from 1 to 2 p.m. The link to register is also on the slide deck and on our website. Additionally, if you're interested in any individual consultation with any of our COE experts on integrated care, please contact us through the form, which is also, the link is also attached to this slide deck. And also, if you're looking for free trainings and credits, you can feel free to reach out to us. Send us an email at integration@thenationalcouncil.org. If you have any questions or you need to reach out to any of us, please do that, and enjoy the rest of your day. Thank you so much for joining us. We look forward to seeing you at our future sessions. Thanks, everyone. Bye.